The human kidney is a high-pressure filtration engine. It relies on a delicate, rapidly pulsing microvascular network to clear waste and maintain systemic balance. When that network incurs structural damage, the decay accelerates quickly. General practitioners and internists are the first to encounter the early signs of this microvascular decay. You serve as the gatekeepers of chronic kidney disease management, dictating the timeline of intervention. The latest KDIGO guidelines require a specific shift in strategy. We no longer wait and passively observe declining lab values. The standard of care now mandates aggressive, multisystemic risk modification. However, many standard practices, like pausing protective therapies because of minor lab fluctuations, are now classified as clinical traps that actively worsen patient outcomes. By applying the newest KDIGO guidelines, we can deconstruct 5 specific clinical traps and upgrade primary care protocols. Surviving the cardiorenal continuum requires abandoning siloed organ management. You must deploy a unified, protective therapeutic strategy. The first trap occurs during routine screening. A patient returns an eGFR below 60. The immediate reflex is to formally label them with chronic kidney disease. A single depressed eGFR does not confirm structural disease. It frequently reflects acute kidney injury, dehydration, medication effects, or a temporary hemodynamic shift. KDIGO enforces a strict chronicity rule. You must repeat the test. The structural or functional abnormality must persist for at least 90 days before the CKD label applies. The corollary trap is assuming that a preserved normal eGFR gives the patient a clean bill of renal health. If you only evaluate filtration rate, you miss the albumin to creatinine ratio, or ACR. Albuminuria is a direct marker of structural damage and an independent predictor of disease progression and cardiovascular events. This grid plots the modern staging guidelines. eGFR and ACR must be mapped simultaneously. An eGFR of 90 with an ACR of 40 mg per gram places a patient in the A2 category. They have clinically significant CKD despite normal filtration. Ignoring the ACR axis obscures structural damage until it is too late, while skipping the 90-day confirmation leads to the overtreatment of temporary fluctuations. You initiate an ACE inhibitor or an ARB in a patient with albuminuria. 2 weeks later, their serum creatinine climbs modestly. The immediate reflex is to stop the medication entirely. This slight creatinine bump is rarely acute structural damage. When you block the renin-angiotensin-aldosterone system, the efferent arteriole dilates. This widening lowers the intraglomerular pressure. That drop in pressure is exactly what reduces albuminuria and protects the nephron from long-term burnout. As long as the creatinine elevation stabilizes and does not cross an intolerable threshold, the medication must be continued. We see similar therapeutic hesitation with SGLT2 inhibitors. Prescribers frequently withhold these agents as a patient's eGFR declines. Current KDIGO guidance clearly supports initiating SGLT2 inhibitors in eligible patients down to an eGFR of approximately 20. Expecting perfect lab stability prevents the initiation of foundational kidney protection. We must learn to interpret and tolerate anticipated hemodynamic shifts. Consider a patient with stage 3B CKD. They are taking an ARB, but their hypertension remains resistant and their proteinuria persists. The third clinical trap is attempting to force the blood pressure down by adding an ACE inhibitor on top of the existing ARB. Routine dual RAS blockade offers no net benefit and instantly branches into 3 hazards: acute kidney injury, hyperkalemia, and severe hypotension. KDIGO recommends an alternative pathway. With suppressed renin and high aldosterone, the correct intervention is a mineralocorticoid receptor antagonist, or MRA. This pathway carries strict caveats. Both ARBs and MRAs reduce potassium excretion. Layering them in a patient with CKD amplifies the risk of hyperkalemia. Layering these agents is only appropriate with strict, timely lab surveillance of both serum potassium and creatinine. When tackling resistant hypertension, adding therapies must match the underlying physiology. Stacking redundant drug classes only compounds the toxicity. A patient with stage 4 CKD presents with fatigue and anemia. The fourth trap is assessing their iron stores solely through ferritin levels. This dual bar chart compares ferritin and TSAT. In CKD, systemic inflammation artificially swells the ferritin reading. The lab value appears adequate, masking an underlying deficiency. Ferritin reflects total stored iron. Transferrin saturation, or TSAT, reveals the actual iron available for red cell production. Under KDIGO 2026 rules for non-dialysis patients, a trial of iron is indicated if TSAT drops below 25%, even if ferritin levels read anywhere up to 299. Relying solely on ferritin leads to a secondary trap, initiating erythropoiesis-stimulating agents before repleting the iron deficit. If an ESA is required after iron stores are full, safety guidelines demand a modest hemoglobin target. Normalizing hemoglobin in CKD drastically increases cardiovascular and thrombotic risk. Treating CKD anemia requires diagnosing functional availability by measuring usable iron alongside total capacity. You must fix the raw material deficit before you stimulate the factory. The final trap occurs in patients with heart failure with reduced ejection fraction. Prescribers frequently withhold optimal guideline-directed medical therapy because the patient has moderate stage 3B CKD. This stems from the misconception that SGLT2 inhibitors are exclusively diabetes drugs, requiring robust kidney filtration to be effective. SGLT2 inhibitors and MRAs provide cardiorenal benefits that reduce the risk of hospitalization and heart failure, independently of glucose lowering. The foundational medical stack for these patients includes a beta blocker, an ACE inhibitor or ARNI, an SGLT2 inhibitor, and an MRA. While CKD alters the monitoring requirements of this stack, it does not remove the indication for its use. The safe implementation of full guideline-directed therapy relies entirely on timely, strictly scheduled potassium and creatinine checks. The heart and the kidney fail together. They must be treated together with a unified, multi-drug strategy. Modern CKD management has moved entirely away from observational waiting. It is an exercise in systemic risk reduction. You must utilize both the eGFR and ACR axes to establish true clinical staging. It requires therapeutic courage. You must confidently initiate RAS and SGLT2 therapies and accept the expected hemodynamic shifts as proof of protection rather than signals of harm. By updating these specific prescribing reflexes and lab monitoring habits, primary care physicians can directly alter the survival trajectory of their patients.